We often hear rural hospitals referred to as the anchor institution in their communities, given their role as an important care provider, employer, and community partner. Historically, many rural hospitals operate on razor-thin margins, even pre-COVID. The current pandemic has exacerbated the financial strain felt by many rural hospitals. As states slowly open back up for business, hospital leaders are beginning to think about the recovery phase and how to develop solutions to ensure the financial viability of their hospitals. Integrating philanthropy into a hospital strategic plan should be a part of a long-term trajectory to promote investment in the health of a community. Welcome to Advancing Health, a podcast brought to you by the American Hospital Association. I'm Tom Hedderly, Senior Writer at AHA. Today we're joined by Alan Smart, Principal at PhilanthropywoRx in Winston-Salem, North Carolina, and an expert in rural philanthropy. Alan will shed some light on the role that philanthropy can play as rural hospital leaders get creative and use their strengths to establish relationships and collaborations to craft coordinated solutions.
Thanks, Tom. I'm Joy Lewis, Vice President for Strategic Policy Planning at the AHA, and I'm here today with Alan Smart. Thanks so much for joining me on Advancing Health.
Thanks, Joy. It's a pleasure to be here.
So, Alan, can you start by telling us about your company, PhilanthropywoRx, how and why you decided to focus your life's work on rural philanthropy?
Well, there's been a couple stages of that. So I did spend about 20 years being a grant maker for rural funders, primarily in Louisiana and North Carolina, both decidedly rural states. And it became clear early on in the work, but certainly as we got a little more sophisticated and I understood what the possibilities might be, that there really wasn't anyone really consolidating the knowledge base about what good rural philanthropy looked like. While there were a lot of great local examples, they weren't really widely known on a national or regional scale. So the kind of mission of the company is twofold. One, to work with funders individually or groups of funders about how to have a more effective rural presence. But the second, and certainly personal to me and what I'm passionate about, is to build a movement or build a field of rural philanthropy that anyone, whether it be a small rural funder or state government or a rural advocacy group, can really dig in and get peers, access what we know works well, present challenging ideas and innovation. And so the PhilanthropywoRx umbrella is meant to as much capture that kind of energy and move people forward as it is to provide kind of on-site individual help to funders.
It sounds like it's been a journey, but you saw a gap and decided to fill it.
Yeah, I always say there's always been a great deal of rural philanthropy going on, but no one really talked about it. And up until recently, very few funders self-identified as rural funders, even though they may have been doing a great deal of rural work. I think part of my mission is to have people really identify as rural funders and really take that with the level of commitment that it requires to be good at it.
So I've actually had the privilege of listening to you speak before, and I've heard you say that seeking rural grants and smart philanthropic strategy is a trajectory. Can you share a little bit more about what you mean when you say that?
Yeah, I think one of the unique aspects of kind of the convergence of rural communities and rural funders, rural grant seeking, and all the elements and players around that is that the bulk of rural funders are in it for the long haul. So they will have a presence, whether they be literally located in those communities or the families have a history in those communities, or they're from a more urban area but would have a rural geography as part of their work. They're going to be around for a long time, and unlike working with a national funder or some kinds of large state funders, there's not an urgency to really get that one big grant or that one conversation or that one introduction that will yield the big grant. What there needs to be is really kind of a developmental path where both the funder and whether it be a nonprofit or the rural community itself are engaged in this ongoing kind of bidirectional learning. And it is a bit of a trajectory. If you think of it as 0 to 10, you might start at 1 or 2, but over the course of 5 or 10 years, you're then engaged in some really deep work that has benefits both to the community and the organizations themselves.
So essentially, funders in this space are really in a niche space, it sounds like, and have sustained interest over the long haul.
Yeah, the funders who are committed to this work recognize that as much as they may have a funding initiative or some kind of relationship or best practice they want to introduce into the rural communities, that it's really about the place first, and that relational type of grant making and philanthropy is where the yield is going to be. And I think it is reasonable to think about that as like this mutually adapted trajectory over time. I think there's an understanding of that on the philanthropic side. Sometimes on the rural community or the rural grant seeker side, they view these relationships as about that single grant or that single initiative, when really the effective practice is going to be trying to build those relationships over time.
So that's a great lead into my next question here about rural healthcare organizations and what we've seen really well documented and heard a lot about their unique set of challenges, most notably providing care in geographically isolated areas with low patient volumes and generally a high reliance on government-funded coverage, Medicare, Medicaid. So can you talk about the opportunities then for the grant seekers, the rural hospital leaders, to establish relationships with funders who are specifically attentive to the needs of rural communities?
Yeah, I think I'll get back to some of my previous statements. Yeah, it needs to be thought of as relational, and it's certainly not about filling a revenue gap or replacing state or federal funding, for example, which is the financial stress in these organizations is such. It's certainly understandable why they might think of grant seeking in that way. But yeah, I always thought, and certainly have seen as I've gotten more into the work nationally, that funders are really interested in talking to rural hospital leaders or, the larger rural kind of health nonprofit structure in any community, really in a way that speaks to some really mutual goals around population health, around supporting social determinants of health, around really the viability of their specific rural communities. And initiating those conversations, ideally, is not about grant seeking. It is about sharing information, becoming part of networks that either the funders may be part of or the healthcare organizations may be part of, really getting to know each other in ways that speak to these larger population health, public health kinds of issues that then end up being as much about economic development and K through 12 education and the infrastructure, the road and broadband infrastructure, as about healthcare itself. So in terms of how to do that, there's certainly some tips that I often talk about of invite people to, work that you're doing in ways that gets their attention, show up where they are. Invite people in from the funder side to talk about what they do, extending outside the sense of this is all about grant seeking, but it's rather about building a philanthropic relationship over time.
So are there any other tips, any other advice you would give that if you put yourself in the seat of the rural hospital CEO who's preparing to have that introductory conversation with a funder, what might you suggest?
Yeah, I would certainly become conversant with the type of grant making that those funders do. For example, there's a readily available list through the IRS and some other mechanisms of, where the grants for the last 5 years went and for what. And often they're with nonprofits that you as a hospital CEO have some relationship with already, whether that's be in a patient support role or a part of a Chamber of Commerce effort or something like that. Seeing what the common relationships are, as well as kind of the common interest areas that might surprise the funder. You may be interested in health care for children in the foster care system in ways that the funder would have never thought a rural hospital would be aware of, for example. It's doing a little homework about what are those already established mutual relationships and then what can happen from there.
Awesome. Solid advice. So I think we might appear tone deaf if we didn't acknowledge that COVID-19 has left a chasm in the budgets of many hospitals, but certainly our very vulnerable rural hospitals. And you recently wrote a piece for the Center for Family Philanthropy entitled How Small Funders Can Make a Difference on COVID-19. What are the key takeaways from that piece that you'd like to share with our listeners today?
Small funders, and by small in a rural community, that might be a funder who distributes $200,000 or $400,000 or $600,000 a year, which would be, large in some rural communities and small in most medium or large-sized cities. But yeah, the opportunities during COVID that a lot of the funders and some of those that I wrote about have really been seizing is stepping into leadership roles, introducing or opening the doors for local entities like a rural hospital to various state and federal officials that they had connections with, whether it be through the board members of the funder or existing grantees. We have been both surprised and a bit frustrated at the number of stories about not just on the kind of the hospital side, but community health centers, rural health clinics, and the associated partners in any rural community health system, and how they've had difficulty getting their phone calls returned or difficulty in identifying the right people to talk to on that kind of regional level within states, but certainly in the state and federal levels. And foundations, the nature of being a foundation means you have networks, you have institutional influence, you have your own board members or associates who can make calls in ways that perhaps a rural hospital can't, in terms of getting attention and trying to provide access to the kinds of state and federal resources that have been made available to COVID. Part of a webinar in a couple weeks where the USDA state representative for Colorado is appearing as part of our session, and she's really going to talk about here's a lot of entry points for work that we do that predated COVID but has been enhanced during COVID, and how funders can serve to be liaisons to their communities, whether it be on the healthcare side or the social sector in general, because she doesn't have that opportunity always to connect to communities or to local institutions. She needs a liaison to help her, identify places for USDA grant applications and ultimately, hopefully, grant funding. So that's some of the best work that funders, smaller rural funders, have done during COVID is step out, identify where there's resources and gaps in information, and really use their human capital, sometimes financial capital, but also as much their human capital to try to kind of move conversation ahead so that their rural communities are on equal footing with some of the urban ones.
You seem to always have some creative solutions, creative suggestions and ideas for possible resources that are already out there and already available. Ways to pursue philanthropic dollars. Can you share what some of those ideas might be with our listeners?
Yeah, I think the USDA example I just gave would be one type of example, but just think about in the midst of COVID and clearly the disproportionate impact on communities of color, whether it be on the neighborhood level or, immigrant communities related to workplace. There are absolutely funders who have dollars out there for that. But, for example, in many rural communities, even though there have been changing demographics over sometimes very near term in the last 5 or 10 years, but often over the last 20 or 30 years, that haven't really been acknowledged or absorbed into the community. I think many, whether it be hospitals or local organizations, don't think that kind of work around communities of color and COVID impact, for example, and kind of support for people and cultural competency, that has much to do with them, when in fact funders absolutely want to engage around those conversations, but it's to some degree up to the rural communities. And if you think of, rural hospital in a leadership role, to step up and say, hey, we are absolutely being impacted by how disconnected our new immigrant community is from the public health system or some of the state systems. And, we really want to talk to you about that to see how we can better connect and create a more cohesive community voice around those who have been so burdened by the impact of COVID. And those are resources that are there, but that funders, in association with their communities, can really work together to shed light on that in ways that don't happen kind of organically. The issue of who is actually living in rural communities around America today versus, what some of these places might have looked like 40 or 50 years ago is one that's not talked about enough, either locally or nationally. And we're really seeing how the marginalization of folks during COVID in these rural communities is really kind of impacting the larger communities, but really opening the drapes on what have been long-term kind of social and cultural marginalization.
Are there other creative ways to get at this work, to really strategically think about how this should be woven into any of our rural hospital leaders' strategic plan? How might they leverage, for example, their trustees or board members to get their legs under them around this kind of work that's really meaningful and has the potential, to your point, it's a longer term trajectory?
Yeah, I think there's two or three options, and they're not exclusive of each other, but yeah, certainly every rural hospital has trustees as well as advisory board members on particular issues who have the network influence and in some cases the time to actually take up some of this work and provide at least that door opening or that kind of public leadership, at least, that allows different kinds of conversations to happen. For most rural hospitals, they're tremendously underutilized assets from both local community colleges as well as their regional university. So not the flagship in the big city, but the place where many of the people from their community went to school and then returned home. And we're often not accessing all the kind of intellectual capital and networks that those colleges and universities have in terms of not just the students who may be able to be put to work on some of this, but the faculty and those institutional board members and how they can kind of shed some light on this. And the third is just re-envisioning existing relationships. If you are a rural hospital, you have some relationship, might be very dotted line versus direct line, but you would have a relationship, for example, with likely the regional older adult services agency. You're providing referrals, you may have board members in common, but those kinds of organizations, now is the time to kind of revisit what those relationships are, that it's just about referring patients on discharge, that maybe now it's time to talk about kind of mutual interests, mutual strategic goals, because those organizations actually often have the staff who are full-time strategic planners or full-time development people who are tasked to have state relationships. And often seeing, and certainly nothing new, but I think it's certainly true during COVID, we're not taking advantage of those kinds of relationships which are there. Frequently what happens, people say, oh, well, we know everyone over there. Well, have you actually sat down at a relatively high level and had a 45-minute conversation about what your mutual interests are? And I think often the answer is no. And that's not a long-term commitment, but just kind of an assessment of what those relationships are. And those agencies often also have their own funder relationships, which you might be able to become part of those networks. Taking another look at what's around you in terms of community assets, as well as reimagining some of the relationships you have.
Got it. So strengthening some existing relationships as well as exploring a broader set of skills in the community that often get underutilized might be a good path forward for
Yeah, to your original question, it doesn't have to be labor intensive. I think what I'm hinting at is I think there's often an appetite from those other kinds of institutions to actually take up some of these issues on your behalf or on the community's behalf, or you're part of it, where you're not the lead and you don't have to have a dedicated staff person. But I think the connectivity between a typical rural hospital and the pressing kind of cultural, social, demographic issues of a community is not as vibrant as it could be, and what can be part of kind of renewing or re-energizing that kind of vibrancy is a different type of connection with the organizations in town that you might have a service relationship with, but not a strategic one.
So, Alan, as you know, the AHA has put together a task force, a Future of Rural Healthcare task force, that is comprised of 28 rural hospital CEOs and State Hospital Association execs. And they've been given the charge to really go forward and reimagine the future of rural healthcare to ensure that future care models are sustainable and the financing mechanisms to support those care models are really also sustainable and are baked into law and regulation. What advice do you have for this stellar group of leaders as they meet on a regular basis and try to, deliberate and contemplate amongst themselves what this future end state ought to look like for them and their peers in rural America?
I think my advice would be more along the lines of it would be worth whatever investment of time they could make, their organizations, their boards, in really charting out who is present in their communities from an institutional and funder perspective that they either haven't spoken to in years or perhaps never knew about. I'm not sure that every rural hospital CEO or their leadership knows that there is a state-based single USDA liaison for every state that you would hope you'd have a relationship with, and on for the federal agencies, and let alone the states. So there's a long list of these kinds of organizations that are operating in your region or available to you that aren't particularly present in your day-to-day life. And, whatever effort, whether it be in the AHA side and really aggregating some of those relationships and providing a manual of some kind that would be specific enough to be useful on a local level, or just providing some kind of ongoing advice or consultation on how to connect with all these institutions. That will be part of any of the population health work long term, and that's certainly broader than rural health care. But I think all of those organizations, whether it be on the governmental level or the nonprofit level, are all in one way or another, notwithstanding whatever issue they're committed to, they are engaged in this whole look at what these rural communities look like forward. And maybe that's 5 or 10 years from now, maybe that's 25 years from now. But I think those kinds of relationships and having those kinds of people who can literally just call up on the phone and say, we're thinking about this, what do you guys know about that? People who are working on that state and federal level, I think that just will bear fruit over time. And it's not something that the funders I'm connected with, who are working with rural hospitals and rural healthcare, it's one of the things they mention frequently. It's like the hospitals seem to be a bit isolated from a lot that's going on around them, understanding staffing shortages and, trying to keep the doors open. But there's a lot more help there than they might imagine.
Well, this has been a wonderful conversation, Alan. Is there one last nugget you'd like to leave with our listeners before we close out?
Yeah, I think the most successful, whether you frame it as population health work or places where community health has been, moved to the forefront and people, are deeply committed, has absolutely engaged people at every juncture of a community. And that's county managers and community college and the ag extension people and, and on from there. It has not been the province of the hospital or public health or government. It's been really where communities have a strong sense that the health, however defined, of their rural community is really one of the bedrocks of what will allow it to sustain. That as long as people are burdened by whether it be chronic disease or some of the more social determinants factors, the opportunities to actually sustain, let alone move ahead, are just really limited. So the places that really see a future are those where I think they're actively talking about these kinds of things and reinventing partnerships and really understanding that health is kind of everybody's business. And it's not the hospitals, it's not the public health, it's not the school nurse. It needs to be hardwired into the culture of a place and how they think about their future.
Health in all policies, right?
Yep.
Well, thank you so much for your time today. I'm sure our listeners appreciate all of the information you shared. I certainly learned a lot about the potential impact of philanthropy on the capacity for rural hospitals to continue to serve their communities. So just want to thank you so much for being with us today.
Thank you for having me. It's been a pleasure.
You've been listening to Alan Smart, Principal at PhilanthropywoRx, and Joy Lewis, Vice President of Strategic Policy Planning at AHA. Their simple message: funders welcome conversations with rural hospital leaders, and the opportunity is huge. This has been Advancing Health, a podcast from the American Hospital Association. Thanks for listening.